Good afternoon, everyone. Welcome to this afternoon MME webinar. The focus will be on telemedicine, the professional and ethical considerations for the family physician. I'm Ying Xian over here, and we have Jingwen from NHGP. We will be your chairpersons for this session. Please note that for the whole 2 hours webinar to be awarded 2 MME points, please stay tuned for the entire session. This will be the agenda for today. The opening will be given by Dr. Suraj. At 2:10, we will cover the current regulatory framework of telemedicine, basically focusing on the essentials, and this will be delivered by Prof. Raymond. At 2:30 to 2:50, we will be focusing on meeting professional standards in telemedicine and what does it take, and this will be delivered by Dr. Andrew Fang. This will be followed by a short break of about 10 minutes. At 3 o'clock, we will commence on the panel discussion, focusing on the case discussion, and we have our panelists with us, Prof. Raymond, Dr. Andrew, Dr. Gary, and Prof. Thiru. This will be followed by a Q&A session, should you guys have any questions. We will then aim to close at 4 p.m., before which a closing statement will be made by Dr. Suraj. We now welcome Dr. Suraj to give the welcome address for this MME webinar that's focusing on telemedicine. Over to you, Dr. Suraj.
Good afternoon, everyone. Welcome to this MME webinar run by the college. In this first 2-year cycle, the college, along with the other professional bodies, will actually be covering the basic principles of ethics and professionalism. But as opposed to just learning principles, I think that the application and medical reasoning involving these principles is what perhaps doctors find challenging in their daily practice. Thus, we will actually have case-based discussions during this webinar using clinical scenarios to illuminate this. And we have invited very good speakers and panelists to help us do this. We decided to use telemedicine as an interesting theme, as there has been much publicity recently, but I must stress that we are not here to discuss specific cases regarding all that's been going on. Rather, we will focus on our case discussions and the principles involved in them. Now, telemedicine does have a place in patient care. Medical technology is advancing in a rapid pace. Doctors may find themselves in a position needing or intending to provide telemedicine as part of their overall care to patients. But it must be used responsibly and always to the benefit of patients, keeping in mind their best interests. So hence, this webinar hopes to help doctors understand, one, the regulatory framework, the professional standards and considerations in ethical reasoning in the telemedicine environment. Thus, before we go on to the case discussions, we will start off the webinar with presentations on the regulatory framework and professional standards. Then after the break, we look forward to a fruitful and balanced discussion by our panelists on the ethical reasoning and approach to these scenarios that we're going to introduce, touching on the benefits and pitfalls of telemedicine. So without much further ado, we have a packed program ahead of us. I will hand you over to our chairpersons to carry on with the afternoon's program. Over to you.
Thanks, Dr. Suraj. We would like to also share a little bit about the CMS Sutra user survey. So CFPS is currently conducting a series of survey reviews on HSG compatible clinic management system for CMS Sutra in collaboration with MOHT. So we'd like to take some time. For those of you guys, I can use your phone or you can type in the form link as well. You can just fill in a quick survey as well. And this will assist the GPs and clinics in their selection of a suitable HSG compatible CMS. Feel free to share the survey link with your GP colleagues as well. We'll just pause there for a few seconds. Okay, we can move on. I would like now to introduce Prof. Raymond Chua, who will be delivering the first part of this session. So he'll be focusing on the current regulatory framework of telemedicine, the essentials. Prof. Raymond is the Chief Executive Officer Designate of the Health Science Authority. He is also the Deputy Director General of Health Regulation, at the Ministry of Health, overseeing the regulations of healthcare services and information. He has extensive regulatory, management, and operation experience in both the public healthcare and private pharmaceutical sectors in the last 25 years, contributing to the advancing developments of the healthcare landscape. Prof. Raymond holds adjunct professorships at the NUS Horsley Hawk School of Public Health, Center of Regulatory Excellence in Duke NUS. He also holds a Bachelor of Medicine and Bachelor of Surgery from NUS School of Medicine, a Master's of Science in Public Health, and a Master's of Business Administration from the University of Nottingham. Without further ado, let me pass the time over to Prof. Raymond. Over to you, Prof.
Thank you, Yuan. Can you hear? Can you see my screen?
Yes, I can.
Good. Let me see. Okay. So good afternoon, everyone. I think thanks to CFPS for inviting MOH and myself to the ethics webinar to speak about the telemedicine regulations. I think like what Suraj has mentioned, this is definitely a timely webinar, as I know there has been quite a lot of queries and concerns that have been raised with regard to how do we look at telemedicine regulations? Can I practice telemedicine now? How do I do so in a safe and effective manner? And I guess a lot of issues continuously increase more, I think, especially with the recent media report on Mana Doctor over the past weeks. But I must also qualify that this is an ethics MME seminar and not a regulatory webinar. While I think the CFPS have asked me to share more about the regulatory context to actually set how we're going to talk about telemedicine first, so that you know how we can go about providing telemedicine as a licensee, as a clinical governance officer, and as a professional, so that we can provide telemedicine in a safe and effective manner. I think as reiterated by Suraj just now, we will not go into the specific case details or advertisement examples. You have any specific examples that you want to raise? You think that there's any other areas that you think are not in compliance with the regulations, including any concerns that you may have, please raise that specifically, either directly to me or to my MOH teams separately after the webinar itself. I also think it's good to just correct a misnomer on regulations here. Maybe a lot of people may feel that regulations is something that is very restrictive, something that will actually constrain a lot of practice. But I think we also want to correct the misnomer here that actually regulations can also be enabling. I think if you remember how telemedicine started out, it started out having a lot of concerns actually, even prior to COVID. Then we decided to work on a sandbox where we actually got the telemedicine providers in. We ran a sandbox. We decided to pilot it and see how things go. And then we decided to see how we can work with the industry to develop some of the regulations. This is where, and then opportunistically or unfortunately, COVID came. But because of COVID and because of the lockdown, I think there has been quite a lot of increase in the telemedicine uptake, and therefore I think telemedicine then became much more mainstreamed. This is where I would want to give you a separate kind of take on regulations. If you remember how seatbelt regulations came about, I think we are also trying to see how we can find a middle ground here. When seatbelt regulations came about, there's been quite a lot of concerns whether seatbelt was constraining personal autonomy. Why should I be putting on a seatbelt? I'm driving very safely. I feel very uncomfortable wearing it. But I think we are now trying to find this middle ground, similar to seatbelt, in which we are also trying to protect public safety, public welfare, enable some of the innovation, where we know that some may feel that this enforces a certain kind of behavior, infringing on your personal autonomy, professional autonomy in terms of how you want to practice. But I think you should take it in another sense that we are trying to foster an environment where you understand what the value of regulations is, and where we are not trying to constrain your practice, but we are trying to give you a safeguard, the safe rails in terms of how you can practice telemedicine in a safe and effective manner. We are trying to engender a safety culture rather, than to say that you are now trying to comply the regulations out of obligation itself. So this is where I think over the course of how I want to go through this part of my talk, I want you to actually hear that actually we are not trying to constrain, but we are trying to give you the safe rails and then how you can, the guardrails and how you can practice it in a safe and effective manner. So let me start. I think I don't have to go into the benefits of telemedicine. All of us know, it can improve access to patient, especially those with limited mobility, increased convenience. A lot of people feel that it's much easier to do telemedicine, especially during COVID. You don't have to go down, crowd with the rest of the people, and you can actually seek care, at the convenience of your own home, reduces the risk of spreading infectious diseases, and especially for those chronic care patients, it can also facilitate the continuity of care itself. And this came very evident as part of home recovery program. But however, we also know that telemedicine, just like any other services, does have a double-edged sword. It's not suitable for all patients. Not all conditions can be diagnosed or managed using telemedicine. Similarly, when you talk about medications, not everything can be safely prescribed through that route as well. And I think we also know technology does break down at times. Some of you would have gotten impacted by the CrowdStrike attack. And we also know that, in fact, a lot of times technology, when it breaks down, it does pose certain risks and impact on the continuity of care. So I think where we also want is to ensure that there's a need for regulations so that it will not be abused. So I wanted to just paint a picture of how you look at telemedicine. When you look at telemedicine, I want you to look at the controls into 4 different pillars itself. I think a lot of focus have been on the professional level, in which how I as a profession practice telemedicine in a safe and effective manner. And if I as a telemedicine do so, then how about the other, what is the role of the other people? So I want to start off with services. And services meaning that if a business, regardless of whether you are a medical profession or you're not a medical profession, you want to start off a healthcare service, we talked about regulations at the HACSA level itself, healthcare services level. And this focuses a lot more on the governance and accountability of who the key appointments holder are. So I don't care whether you are a profession or medical or non-medical profession. If you are a licensee, you set up a business, you need a licensee. You need to have a principal officer which looks after the day-to-day operations. You need a clinical governance officer, especially for the highly complex ones or the technical matters where you need to come up with technical clinical protocols to guide the doctors in terms of how they should run the services. And this includes the advertisements of the licensable healthcare services itself. So it means that does not mean that you actually set up a business and I rely everything on the doctors to do the business and I'm out the hook. It is also the responsibility and accountability of the business owner and whoever is the business owner that employs the doctors, and there's a clinical governance officer which looks at ensuring clinical protocols are put in place. And then after that, we talk about the professionals. Of course, the professional is where the professional interacts with the patients. And then because of the direct clinical care that's being provided by the professional to the patients, then the ethical codes come in. And that's where the ECG or SMEC comes in. Then that will be the professional standards and ethical behavior of how you should also be providing care comes in. And then, of course, that also includes advertisements of a professional practice. Healthcare professional practice. So just now when we talk about advertisement, it's at the services level. As professions, you can also advertise your services itself. And this is where the ECG advertisements come in, and I'll elaborate a little bit on that later. Then of course we know that there's also products. When you administer any kind of services, there is products being dispensed. And I think this is where the Health Products Act comes in. And that is where we talked about how do you actually look at supply, prescription, dispensing of health products. And that is both at the services as well as the professional end. Similarly, as a services, you need to ensure that you have the necessary guardrails to ensure that the products are being saved properly. I won't put the onus on the professionals because the professionals are only at that point in time dispensing the products to the patients itself. So the services and the business owner is important to ensure compliance to the Health Products Act. But of course, at the dispensing end, when you see a patient as a profession, then you also need to ensure that whatever you give is in compliance with the indications that is being approved by HSA itself. And this, again, Health Products Act has inclusion of the advertisements of health and therapeutic products within the Act itself. And lastly, we talk about information, and I think this is where later on next year we are passing a health information bill, which will then focuses more on the data collection. How do you look at taking data into the NEHR, safeguarding data at NEHR, etc., etc. And I think I will not focus today's presentation on that, but basically at the services, professionals, and products, and it's what I will be focusing on. So just a brief overview of HCSA, the Healthcare Services Act. It was enacted in 2020. Basically, I think previously it was focusing a lot more on premises-based. It was the Private Hospitals and Medical Clinics Act, but it was only a premises-based regulatory regime, and it couldn't cover things that are outside of the premises itself. And that's why we decided to move to a services-based. And with that services-based regime, it then allows us to regulate new care models. That's why we came up with the 4 modes of service delivery for each of the services that we will regulate. So similar to what we have previously under PHMC, you can have a permanent premise where you will provide services from the brick and mortar side of the house. Then we note that there are similar to, you see that there's a lot of food on wheels, there's ambulance services, there is also certain radiological services that's on the move. We also note that there can be conveyances that will provide some medical healthcare services itself. Therefore, we created what we call a conveyance mode. At the same time, we note some people may decide not to have a permanent premise and not to have a vehicle, and they may just want to provide care on the move, so going to people's homes, setting up temporary booths, so that is where we say, okay, we create a new mode of service called temporary premises. And then, of course, we also have the 4th mode of delivery, which is remote mode of service delivery, which is where you can provide services through platforms, applications, phone calls, etc. And that's through telemedicine, and that's the remote part of the house. And I think for most of the clinical medical service at the outpatient level, we have given you the service license at the permanent, temporary, and remote. That means at the same time, while we get a permanent, we know that most of the people will provide home house calls and will provide some form of remote telemedicine services as part of the continuity of care. And therefore, when you apply for one, generally you will get 3 unless the licensee has decided not to opt for the additional service. Similarly, if you do conveyance, then we'll give you temporary and remote, but we decided to split permanent and conveyance because not everyone, when we were doing the service mapping, not every permanent premise will have a conveyance one, and we decided not to load too much regulations on the permanent premises by not having conveyance within the whole care regime itself. So when we talk about the regulatory regime, this is how it is being usually, the 101 of regulations is that there will be an act, there will be regulations, and within the regulations, there will be general regulations that cut across all the licensable services, which includes how you look at advertisements, how you look at fees, how you look at appeals, and then there's the specific service-specific regulations. So in this case, for the clinics, it will be outpatient medical services. And within that, we will have additional requirements in terms of the licensing conditions if you have remote provision of services itself. And today, we'll be zooming in more on the remote part of the house. So I just want to break it down easier, for the audience here. Basically, when we talk about the telemedicine, when we have the regulatory regime, I break it down into 3 components. One is before teleconsult, during teleconsult, and after teleconsult, and what the roles of the licensee and the clinical governance are. So generally, the principal officer will be one that looks after the day-to-day provision of the telemedicine services, while the clinical governance officer will be the one that provides the clinical governance and clinical oversight over the telemedicine service. So you need to put in clinical protocols, how you look at reviews. If there's any challenging cases, actually the clinical governance officers should work with the professions, come up with reviews of cases, and then the licensees is one that have to ensure that the principal officer and the clinical governance officer that they appoint have the necessary training, competencies, and authority to do so. Then they also need to make sure that there's proper training, continuous training, to ensure that they continuously meet the necessary competency. And if there's any changes that's being reflected by the professionals and escalated up to the licensees and the CGO, they must then review the necessary clinical protocols and processes. So it does not mean that you set up a business, there is nothing you need to put in place. Actually, when we go down to inspect, we want to actually look at the clinical protocols and processes that you put in place for the doctors itself. You cannot be setting up a practice and then just saying that, okay, I'll let the doctors run the show. And then you just employ doctors and thinking that the doctors will run the show properly and just pass on the onus to the professions themselves. That is not correct. We actually want the onus to be at all levels, including that of the licensees as well as the clinical governance officer. And therefore, you have to put in place necessary protocols to ensure the safe patient selection. So it does not mean that you leave it to the profession. Actually, at the business level, you need to ensure what are the protocols on who should not be receiving telemedicine. You should guide the doctors that you employ. Just like any factories, when they start a manufacturing line, they also have to tell the workers what can or cannot be done. It cannot be I leave out to the doctors, the factory workers, I build a factory line and then there's no good manufacturing practice, good distribution practice, whatever. You need to actually have protocols to train and guide the doctors that you employ. So you need to have these protocols, tell them who should not be receiving telemedicine. Who are those what are the medical conditions that cannot be adequately assessed by a telemedicine? So, things like ankle sprain that you think will require physical examination, any emergency patients, like for example, chest pain, shouldn't be accessed through telemedicine itself. Similarly, types of drugs that cannot be given through telemedicine because there's a high risk of abuse, like codeine containing cough mixtures, benzodiazepines, hypnotics. Similarly, we have also started to see quite a lot of people asking for erectile dysfunction medications, and we do know that some of these medications require blood pressure monitoring, which is definitely not the standard of care that you provide during telemedicine itself, and you require a face-to-face consult to be able to do so. So you need to put in place the necessary protocols for that. Then after that, you need to ensure proper triaging. Some clinics we see have a triaging process, that is done and it's put in place before the healthcare professionals come in. Then if the triaging is done by a healthcare professional who is not a medical practitioner, like for example, the nurse or the allied health professional, then it should be supervised by a medical practitioner, which means that you need to make sure that there's a triaging protocol that's put in place. And if there's anything that deviates from the protocols, then it must be escalated to the medical practitioner for an advice itself. And the triaging should not be resulting in a diagnosis, treatment of a medical condition, prescription of medications, or issuance of any MCs. So you cannot leave it and say that within the protocol there is this protocol, and once you go through this protocol, you result in the triaging of issuance of MCs, and therefore that can be done by a non-medical profession. That is definitely not allowed. So nurses working under the supervision of the doctor to answer phone calls, requiring any minor ailments, if there's any medical advice or medical management that's needed, then that has to be escalated to a doctor for a teleconsultation itself. So this brings me to, how do you look at telemedicine when we start the telemedicine? It should not be provided solely by a self-service or text-based questionnaire. So it cannot be like, there was a case and there was pocketcare.sg, in which we was just answering like a chatbot like that. There's text-based, and then at the end of it, you will just spit up an answer and say, okay, now you have this diagnosis, or you can get certain medications, or you can get certain MCs. It cannot be done in that manner. If you want to do any of all these chatbot, number one, if it may be a medical device, if it comes out with a medical diagnosis, and that needs to be registered with HSA. if it doesn't count a medical diagnosis, treatment, or advice, then we also need to make sure that the algorithm must be signed off by a registered medical practitioner and should not be prescribing any medications or issuance of any MCs, which constitutes treatment itself. So it does not mean the chatbot can be just run by a businessman. Somebody at the end must validate the clinical algorithm itself. Then, as per ECG, I think we are aligned to ECG, where we say that if it is a new patient, if there's no prior patient records or medical history with the licensee, that means within the licensee itself, you are the first time seeing the patient, then you need to ensure that there's a synchronous video consultation. Synchronous meaning there must be a face-to-face consultation itself. Why is this important? Is because there is no prior doctor-patient relationship being established itself. And therefore, you will not know what the patient's condition is, not even on your own clinical case notes. And if that is so, there is a need to ensure who are you talking to, have a face-to-face, have a general examination, talk to the person, at least document down what is the general profile, patient, whether the patient has any allergy, etc., rather than to just do it either on a text-based consultation or phone call without even seeing the patient. So that is for new patients a mandatory requirement. And then if it is provided by a platform, and we do know that now because there's platform, many doctors may jump onto the same platform. It is also very important that it must be very clear to the patient, both before and during the teleconsult, which is the licensee that they are receiving telemedicine under. So it cannot be you are jumping to an ABC platform and everybody thinks that ABC platform is providing the teleconsult. It's actually ABC platform that's providing the consult, but XYZ clinic is the one that's doing so, and that must be made known to the patient itself. And then it must be conducted in a place that is close and private, and there must be a full view of the face of the healthcare professionals, and the healthcare professional should also introduce who he or she is. And we have heard and you have seen from the news that sometimes teleconsultations, because it is so convenient, it is held sometimes not in a private place. Sometimes we heard complaints that it has been held in a shopping center, in a bar, in a restaurant, and they can actually see the background of people walking in and out and streaming in and out around them. That does not constitute privacy to the patients, and that is definitely prohibited. Then we go on to follow-ups. After the teleconsult, I think the telemedicine providers should put in place what the clinical protocols are. Then who should you see as follow-ups? How should you look at the follow-ups? What the frequency of follow-ups. We leave that again to the CGO in consultation with the professions. It can be if the person is well controlled, then definitely the follow-up may be lesser. If it is more controlled, then it should be more frequent. And this we leave it to them. There must be a clinical protocol in place. And if there's any teleconsult that was incomplete, where information was not given properly, like for example, poor connectivity, you cannot hear, or you think that there's a need to follow up itself, then arrangements and alternative ways must be made for in-person follow-up care itself. So if you need a blood test, then you either arrange for a physical visit or you go down to do the home care visit to require the blood test to be taken. So in overall, I think under the regulations, the telemedicine providers, in addition to the doctors, it's important to ensure, and that's why there's an overall phrase that there is the need to ensure that there's proper, effective, and safe care that's being done, provided for by the licensee itself. You should then regularly review the services provided by the doctors to ensure that there's proper clinical assessment. So that's why there's a need for a clinical governance officer. That's, again, I must reiterate, a lot of people always come to me and say, why is the businessman, why the businessman who is not a medical profession don't know how to run a service, but there's a clinical governance officer. And what's the role of the clinical governance officer is to work with the doctors on all these issues. So if there's improper clinical assessment, if you think that there is, and we have saw good practices by telemedicine providers, in which if there is multiple issuance of MCs, they actually go in and it's actually escalated and reviewed internally. And if they feel that there is an abuse, they will actually either reprimand or warn the doctors, or they will put in place a much more tighter regime to ensure that whoever is coming very frequently to see the doctor, then there is either remedial training for the doctor, or they will ensure that the patients come in to see a physical consultation itself. Similarly, documentation is also very important. We do know that there's limitations of telemedicine, and therefore, if there is any form of limitations, that should similarly be documented down as well. And if there's anything to do with how, or what is the date, what is the time, what is the method of communication, similarly, that should be documented on the case notes. And there should also be proper documentation in terms of the date, reason for the MC issuance. And I think in mid-October, we also sent out a revised regulatory requirement in terms of issuance of MCs. We do note that MCs previously need not have the name of the doctor as well as the MCR of the doctor itself. But now, because we have also seen quite a lot of MCs being just signed off without knowing who this signature is, you know, I think legally, this is actually not tenable because MCs is a legal document for schools, employers, or even the courts itself. We do need to know who this signature belongs to, and therefore we have put in place as a requirement that there must be a name and an MCR number that's tied to a signed MC. And if it's not a signed MC, it's electronic generated MC, then at least there must be a name and MCR number itself. I won't go much into the next two slides because the next two slides are basically, I just wanted to give an overview of what are the ECG, and I believe our next speaker will be talking more about this. But I just give you a snapshot of under the ECG, which are the appropriate level clauses that's needed for group clinical care, you know, where there must be good clinical practice. How do you evaluate the patients? And again, I think A6 is very important. You know, telemedicine is not equal to conventional in-person care, and we do know what are the limitations of telemedicine. And if you think that it must be adequately addressed through seeing a patient physically, then please arrange for the patient to come down for in-person consult itself. We do know the challenges, and I think later on during the case studies, we will go through some of this. Similarly, what is the good clinical practice? You know, how do you maintain good, clear and accurate medical records? How do you look at MCs? And MCs, again, I want to reiterate that it must only be given after proper clinical, after good clinical assessment itself. It cannot just be issuance of MCs for the sake of issuance of MC because the patients want it. And we have seen from a lot of audits and inspections, patient want 2 days of MC, plan 2 days of MC. You know, and there is no clinical assessment, no clinical medical grounds, and that is definitely in contraventions of ECEG itself. And similarly, for prescription of medicine, no different from MCs, there must be a clinical there must be a clinical assessment and how you actually give the medical grounds itself, you know. So it cannot be a patient requested for Panadol, you know, and there's no signs and symptoms being given and just give Panadol itself, you know. It may not be that there may also be evidence that there may be a medical ground or clinical assessment done, but then it will relate to improper documentation because that's then not documented properly itself. So documentation also plays a very big part in determining whether assessment has been done properly. So I just want to give you a quick snapshot, like for example, you know, this is what we see and what we hear. You know, I will initiate a video call soon. How many days? Call ended in 17 seconds. 2 days will do. Here's your MC. You know, if you still are unaware, please consult me again. What you see on the notes is just URTI, request for MC times 2 days. No clinical assessment. I don't know. You may say that I have done a clinical assessment, but not from the documentation. I'm unable to ascertain whether the clinical assessment has been done properly. You know, so all these things, and then it finished within 17 seconds. So of course, I'm not able to ascertain. Within 17 seconds, you could have done even checking the allergies, ascertaining how long was the flu, how long was the fever, how high was the fever, nothing. So this is where I just wanted to paint how this in itself shows the inadequate clinical assessment that's being done. So last but not least, I just want to touch on advertisements. Advertisements, 2 areas. We are talking about advertisements at the service level. So the service business can also do advertisements. When we look at advertisements, we look at the contents. The contents must be factually accurate, must not be false and misleading. It cannot allow you to go and compare and contrast your quality, I'm better than the other, cannot depreciate the services by another licensee, and cannot be providing information as to solicit or encourage the use of the service itself. So I give discounts, I give to a usual price $20, now it's $5. Now, all these things is considered as continuously encouraging the use of services. How does it relate to telemedicine? I just want to give a quick snapshot, and this is what we are going to actually also communicate to all the medicines, all the providers, and things that are going to indicate that MCs can be easily taken. Whether you are creative or not, medical consultations from $8, and you put down the MC from $8, I'm insinuating, yes, it's medical consultation, but it's also MC from $8, 1 minute registration, etc. As long as your advertisements indicate that MCs can be easily obtained, we will take it that there is evidence that there may be soliciting or encouraging the use of the service, and it is not allowed. Similarly, if it is promoting fast consults, so we have also started to see quite a lot of advertisements like, oh, forget 1 second consults, we do $1 consults, etc. Similarly, if you want to say that you can complete within a stipulated or specified duration, not potentially misleading, okay, because it may not be true that it can be completed within 1 minute. Again, if you want to compare with other telemedicine provider, even if it is not named, if the references based on information in the public domain, and we do know 1 second consult has been linked to quite a lot of other licensees, similarly, it is also not allowed. We know once we cramp down on services advertisements, and this is from our experience, the next that will come will be professions. We will say, okay, I won't advertise at the services level, I advertise at the professional level. Similarly, I will say that the same requirements will apply at the professional level. So doesn't mean that you don't put in your clinics, you put in the profession. There is no regulatory principles around it. There is still ECEG, which will similarly have that thing about not misleading, ensuring that it must be appropriate to the dignity of the medical profession, and any professional breaches of regulations will similarly be referred to SMC itself. Then lastly, I think we do know that the platforms now also can be advertising services. So rather than advertising at the clinic end, you may use the platforms to do so. We also have the necessary regulations that will ensure that there's proper advertisement by platforms. Platforms will need to be authorized publishers. So if you ask a platform to publish, to do advertisements, then they will also need to comply with the HACSA advertisement regulations. And if you didn't, and the platform does the advertisements without your knowing, then they are considered as non-authorized publishers, and we can also take the platform to task. So lastly, I just wanted to also talk about advertisement of medicines. And we also know that some people advertise medicines, so I want to mention that under the Health Products Act, advertisements of specified health products regulations, advertisements of prescription-only medicines are not allowed under the Act itself, especially if you are talking about those that you are going to advertise with regard to without any reference to any medical conditions, which as that has the effect of soliciting the consumption of telemedicine itself. So I'll give a few case examples in the next slide. But similarly, if you talk about P only, while it can be advertised, then you also need to ensure that there is a display of the advisory or warning statement, like how we've seen this deflam advisory somewhere in the advertisement itself. So if you are advertising, promoting weight loss POMs, which appears to indicate GL1 injections suitable for everyone, while you may not have named the product, it is still a prescription-only medicine, it is not allowed. Similarly, erectile dysfunction POMs, which give the impression that such POMs can be used without consideration of the patient's medical conditions, without naming it, it is because it is a POM, it is also not allowed. So in summary, I just wanted to give you 3 broad areas. So I would say at the services licensee level, good governance is key to ensure that telemedicine is provided in a safe and effective manner. The licensee is responsible together with their key appointment holders like CGO, etc., to ensure. So it cannot be just passed on to the professionals itself. Then professionals, of course, when you see the patients, you have the responsibility to uphold professional standards of care, to the patients. So yours is at the face-to-face level with the patients. The business is at the services side. And then, of course, products cut across both depending on when you are talking about the use of the products, whether it's at the storage or supply end or at the dispensing end itself. So everybody has a role to play. I think I know I talked a lot more on the regulations, but I think a lot more also got to do with the ethical practice of the professionals as well as the licensees if you are a profession. So there will be a MOH circular that will be summarizing what I mentioned, so that we we want to be more crystal clear in terms of some of the requirements. There may be quite a lot of, I would say, probably misinformation, lack of understanding, etc. I think we want to now put within the circular and align everybody's understanding to it, and hope that everybody understand we are trying to create a safety culture, trying to ensure that everybody comply for the sake of patient safety and not complying for the sake of just meeting the requirements here. Good, thank you. Sorry, I went out a little bit about time because I think there's quite a lot of things to cover itself. Thank you.
Thank you. Thanks very much, Prof. Raymond. Okay, we now move back to the presenter slides. Thanks, Prof. Raymond, for sharing. Thank you.
Thank you.
Before we move on to Dr. Andrew's presentation, I'd like to thank Prof. Raymond for covering the regulatory framework for telemedicine under HCSA, also giving us a broad overview of the regulatory requirements for practicing telemedicine, our professional obligations under ECEG, including maintaining good medical records, MCs and prescription of medicine after adequate clinical assessment, and last but not least, professional and ethical standards on telemedicine-related advertisements and the need for us to comply with current regulations under the Health Products Act. I would like now to introduce Dr. Andrew Fang, who will be giving us his talk and his view on meeting professional standards in telemedicine. What does it take? Dr. Andrew is a family physician with a passion to use technology to improve healthcare delivery. He graduated from NUS School of Medicine in 2010 and obtained the Master of Medicine, Family Medicine in 2016. He also holds a Master of Technology from NUS. Since joining Dr. Anywhere as a hybrid doctor 3 years ago, he attends to his patients in his clinic over telemedicine and in their homes. He's currently also head of the Medical Affairs Department at Dr. Anywhere. So Dr. Andrew, over to you as you continue to share from a platform perspective.
Thanks, Yin Xian. Give me a second. Let me just load up my slides. Okay. All right. Can you see?
Yes.
Okay, great. Yeah, thanks. I just want to thank the organizers for inviting me to speak at this forum. I'm Andrew. I'm a family physician, currently practicing at Dr. Anywhere. I've been seeing patients over telemedicine for close to 3 years. And I also played a CGO role for the Dr. Anywhere telemedicine platform. So today is my pleasure to spend the next 20 or so minutes talking about this topic, meeting professional standards in telemedicine. What does it take? So, I mean, just to scope the presentation a bit more, I think for professional standards, there are a whole variety of concepts out there, but I think chief of which are the two biggest font terms in this word cloud. I would say quality and safety, which is what I've actually chosen to focus on a bit more in this presentation. I may touch on other aspects like ethics, managing conflicts of interest and confidentiality, but really the focus will be on quality and safe care. The other thing I would like to just scope a bit more is the sort of telemedicine. I think if you read the guidelines, the National Telemedicine Guidelines, they talk about the 4 various types of telemedicine. Today, I'll really be focusing on the teleconsultation type of telemedicine, which is the interaction between healthcare professionals, mainly doctors, and patients or their caregivers for direct clinical care. So with that, maybe I'll just give an overview of how I intend to approach this question on meeting professional standards in telemedicine and what does it take. So I'll try to answer it from 2 perspectives, one as a platform and the other as a practitioner. So for the platform perspective, I will share what we do at Doctor Anywhere, our approach, so I can perhaps give a bit more realistic examples. I would say by no means ours is a model approach, but it's what we've been doing and what we find has so far worked fairly well for us. So just a quick introduction on Doctor Anywhere. We were founded in 2017 as a telemedicine platform. We were actually part of the sandbox that Prof. Raymond was talking about. And over the past 7 years, we've grown into an omni-channel healthcare company. So these are, on the right side of the slide, these are our various channels which we deliver care to our patients. Today, really the focus is on the telemedicine channel and how we work closely with our 100 or so GP partners to ensure that everyone meets the professional standards that we expect on our platform. So before I answer the how, I'll just explain a bit of the why. So really, we believe at DA that being a platform that ensures provision of safe and good quality care is our primary responsibility as a healthcare provider. And really, it's also in our business interest to do so. So for the how, I would say we have 3 pillars that we use to ensure that our doctors maintain professional standards on our platform. The first is onboarding and training. The second is through monitoring of quality and standards. And the third is through some accountability and quality assurance systems that we've developed. So I'll go through each of the pillars one by one. So for onboarding and training, and I've just highlighted some text in red to indicate which I feel are a bit more unique to telemedicine. So for onboarding and training, we do have a selection process for applicants who wish to join our platform. Not everyone who applies eventually gets to onboard. What we do is we review the standard qualifications like professional licenses, past training, their CV, where they're currently employed. And we also specifically look out for the MOH telemedicine e-training participation because we feel that this is really an essential course for all doctors who intend to practice telemedicine to go through. Apart from that, we also look for the experience level, not just in terms of the years of experience, but the type of experience, preferably for those who have been through primary care, polyclinics, or even emergency department work, because I think the doctors really need to have that additional level of confidence to deal with the uncertainty, the additional uncertainty that might arise from dealing with cases over telemedicine. For those who we select, we will invite them to come down for a mandatory face-to-face onboarding training in our HQ office. This happens usually once a month. The purpose is really to from the start, set the standards and the expectations we have, and also to give the doctors that confidence to be proficient and see patients well over our platform. So the sessions usually take about 3 hours long, and we go through various aspects of administrative, operational, things like the patient journey, and then also definitely the professional, ethical, and clinical aspects that are pertinent to our platform. After they finish the face-to-face onboarding, we will then do a 3-month assessment period to really assess the doctor in terms of his or her suitability for telemedicine. What we've encountered is sometimes some doctors are a bit more cautious and practice very defensive medicine, And there may be also other doctors who require a bit more hand-holding with the digital technology tools that we have. And of course, for doctors who are already on our platform, very seasoned, we still create learning opportunities for them to continue upskilling, to learning new things, refreshing knowledge. And this is especially so if we, when we roll out specific or new telemedicine programs. So one example is our GP-PEDS VC training, which we are rolling out, or which we are doing in anticipation of child health service rollout. We also use our platform to regularly share learnings from any feedback, clinical incidents, and near misses that happen on our platform, really to keep the doctors vigilant and careful as they continue to practice on our platform. So that's the first pillar. The second pillar is that of monitoring of quality and standards. Here we use a combination of passive and active monitoring mechanisms. For one of the passive monitoring mechanisms is through patient satisfaction ratings. I think this is pretty unique to telemedicine because in clinic, I don't think a lot of patients will actually give a rating, but over telemedicine, this is shown to them, the patients, after the call, while they're waiting for the medicine. So they give some ratings of how they felt the consultation went. And one of the questions is really specifically on the doctor's service level. So we, through these ratings, actually compile or compute a score, which we track very closely on our end. And we also share these individual scores with the doctors themselves, so that they can do some self-reflection on their service level. We also do receive feedback and definitely complaints from patients. We have an SOP on how to handle these complaints. Usually we'll try to get input from the doctors also. We'll look at the case notes, but I think for telemedicine, we also have the opportunity to look at certain metadata, things like the call duration, the call quality, was the camera on, was the audio problematic, and these actually help us to make a better judgment of what exactly happened during the call. We also have active monitoring mechanisms. So we do quality checks, means are really random spot checks to detect any irregularities on our platform. Things like deviation from guidelines, overprescription of certain medications, or off-label without much explanation or discussion, or things like when the case notes are not very complete or the call durations are short. These are things that we will further investigate if we pick up during our quality checks. On a larger scale, we also do audits, and these are into various areas like MC issuance, to see any reasons for long MCs or frequent MCs that were issued, or also into medical record documentation. And now I'll move on to the third pillar, which is accountability and quality assurance system. Actually, this pillar works quite closely with the second pillar. So any lapses or doctors falling short of professional standards, we will then have these accountability and quality assurance systems that kick in. So the first is through penalties. We operate based on a principle of shared accountability. So if really there was a lapse or something, an error, or doctor falling short of the standards, we will actually get the doctor to bear the cost of the service recovery, either full or partial. So examples would be if there was really insufficient medication that was prescribed, or if the patient complained that the concerns weren't fully addressed, and through our assessment we deem that it's truly so, then that's when we will actually maybe get the doctor to do an unpaid reconsult with the patient, or maybe have to bear the cost of the refund. The next accountability and QA system we have is a tiered system for case assignment. This is something like a carrot and stick model that we use. So generally, those doctors who really perform well on our platform, constantly receive good feedback, we'll actually assign them a higher priority to be assigned cases. Whereas on the converse, those who repeatedly make a lot of errors and get complaints from patients, they will get lower priority in being assigned cases. And the last we have is what we've developed as a provider service improvement system. This is the purpose of this is really to identify doctors with certain service challenges and to see if we can help them improve. So it's really like a traffic light system. All our doctors, we start at the green level. But if really there are some service quality incidents, like the error or feedback that we deem is valid or complaint that's valid, we'll then log it as a service quality incident and move the doctor to the next level and so on. At each level, we have action items we do with the doctor, like a written acknowledgement and what things they will do to kind of prevent a similar incident from happening, to getting them to come down for refresher trainings, and then subsequently even direct observation of how they do telemedicine consults. Of course, they don't stay at a certain level for permanently. If they really improve, then after a certain time, they will actually move down again to back to green, hopefully. But of course, we've also seen doctors who are a bit more recalcitrant and really move all the way red and off board from our system. So really, these are the three, I would say, core pillars that we use to ensure that we meet professional standards on our platform. But I would say there are also other contributing elements that help to enable this. The first is we're very fortunate to have a very strong peer support. We have a cooperative network of doctors who I would say have a certain high standard that they personally maintain. And this, I think, provides a positive influence for other doctors, especially newer ones who join the platform. Some of them, they also serve as our surveillance system. So they also do flag up some irregularities that they notice, which we will then have to further investigate. We're also fortunate to have good management support that I would say not just values patient care quality, but also prioritizes it. So they do support the need for, like what Prof mentioned, guardrails, especially when there are new innovations that we're thinking of launching. And then the last is we do have ancillary teams that are also very that recognize the importance of our doctors maintaining professional standards. So they really take the effort to co-design programs and workflows with our doctors, so as not to come up with something that really compromises our professional standards, but instead to make it easier for us to do so, to maintain our standards, or to elevate the standards. So, I mean, my answer to the first part of the question, what does it take as a platform, is really, I would say, a whole of company commitment and effort, and a fairly good understanding of telemedicine, where its pitfalls and opportunities lie. So now I'll just move on to the second part, which is what does it take as a practitioner? And really, these are learnings from my own personal experience over the past 3 years. As I was preparing this, I was trying to recall all the various cases that I saw that may be relevant to this talk. I came up with a list. I would say it's not exhaustive, but tried to distill it into maybe what I call the 4 Ps. So I'll go through the 4 Ps in this slide. The first P is really the provider's limitation. So I think we're all aware that it's very difficult or actually not feasible to examine a patient over telemedicine. So what, as a doctor, we should be mindful of is that we really have to be comfortable with dealing with the additional level of uncertainty. And to mitigate the risks that arise from the uncertainty, I think we probably need to sharpen our shared decision-making skills and maybe other skills even to effectively communicate and arrive at an informed decision with our patients. We also have to be mindful of our documentation. Unlike physical clinic where we can really do a lot of different examinations, telemedicine is a bit more limited. So to be accurate with what we document, we should only document what is observed. So shouldn't put things like cranial nerve 1 to 12 is normal, that sort of thing over a telemedicine consult. We also have to be mindful that there may not be a clinic assistant to assist us at times and on certain platforms. So as a doctor, we have to be prepared to perform certain tasks that we usually rely on clinic assistants to help us with. So things like patient verification during the registration process, counseling on medications, doing the additional layer of drug allergy checks, booking the next appointment. And also, there may be cases where we may need to visualize a certain more sensitive body area, but if there's no chaperone around, then we may have to kind of deem that consult to be not suitable to be done over telemedicine. The other P, the second P, is the patient expectations. I think given the convenience of telemedicine, a lot of patients, I think they may come in with the mindset that it's really a casual kind of chat with a doctor, but I think sometimes it can be too casual. So I've come across cases where patients really call in while they're driving with possible compromise to their own safety. Sometimes they call in from public area, asking for emergency contraceptives with a speaker on. So that also compromises their confidentiality. So I think as professional, we have to be aware of this. And I think if we encounter such cases, we probably have to counsel and educate the patient appropriately. I think some of them, they have the expectations that what we can do in clinic, we can also do over telemedicine. So similarly, we have to be prepared to manage those expectations and counsel appropriately. Some cases are like parents calling in to certify their child clear of HFMD over a video consult. Some expecting longer MCs where we are unable to examine the patient. And some really like with symptoms that, I mean, as a healthcare professional, you would think should be seen in the clinic face-to-face, but patients still calling over telemedicine, mentioning that they haven't been to a clinic before, expecting you to really do something about their condition. The third P is their processes. So I think it's now over a digital medium. So it's a bit more difficult to establish good rapport with the patient without that face-to-face physical interaction. So I think it's not impossible to establish good rapport, but we probably have to put in more effort in other areas like active listening, maintaining good eye contact, and providing more explanation to establish a rapport so that we can kind of have a good therapeutic alliance with the patient eventually also. We also have to be a bit more vigilant to pick up certain visual cues that over the telemedicine platform, especially because we can't have the full view of the patient in his or her surroundings, not sure who is around, kind of maybe even talking to the patient during the call. So definitely there may be certain patients who may be calling if it's a cry for help, or maybe also even under undue influence from others during the call. And then there's also that other thing about lower digital literacy, both for doctors and patients. So some patients who are lower in literacy may need more guidance on the post-consult process in terms of how to really, which buttons to press to order the medications. Come across some cases where the consult ended and the patient didn't know how to get the medicines or how to download the digital MC from the app. And then as doctors, we also need to be proficient with the digital tools that we have that enable us to conduct a good teleconsult. So how to work with the earphones, Bluetooth, how to troubleshoot. And then if we do decide to utilize certain medical devices like digital stethoscope, we also have to be familiar with such things. And the last is the policies, which I would say encompasses regulations and guidelines. So I just mentioned two here. One is the documentation. So I think we have to be aware that for telemedicine, there's additional requirement to document the T on top of the usual SOP that we document. For those who are not familiar, the T is really the telemodality, telelocation, timing. I think the telemodality is a bit more important because there are various types of telemedicine. Some, like what Prof showed, text message, some are just a simple phone call. And then, of course, the ones that we do on our platform is the video call. So most of our doctors, when they onboard, we tell them, please put the T on top of your usual documentation. Then for prescriptions, yeah, there are certain restrictions also. One of which is that external prescriptions are not accepted by our pharmacies, because what they need is a wet ink signature. So this is something I think new doctors who are new to telemedicine may have to be aware of. Otherwise, you may end up getting the patient to go to various retail pharmacies and not getting his prescription or prescription filled. Yeah. The other thing is some medicines on the first schedule of the Misuse Drugs Act that cannot be prescribed over telemedicine. Yeah, so these are the things that Prof went through. So these are some of the regulations that I think any doctor who is keen to start the journey on telemedicine should be familiar with. So the HACSA regulations, then the licensing conditions, the National Telemedicine Guideline, then go to review the section on telemedicine SMC ECG. And also, I would strongly advise that if you're intending to do telemedicine, yeah, to do the MOH telemedicine e-training. It's a very useful course. So yeah, this is my takeaway message. So what does it take as a platform? Really, it's a whole of company effort to build a good platform with certain systems in place. And when thinking about how to develop the systems, don't just worry about the pitfalls, but also think about where the opportunities are to kind of build even better systems. And as a practitioner, do consider using the 4 Ps. This is really something I came up with. But I thought it'd be something to be a bit more encompassing as we think about the different pitfalls that we may encounter as we embark on telemedicine. So yeah, that's it. I've come to the end of my talk.
Thank you very much, Dr. Andrew, for sharing. Thanks for sharing your perspective on telemedicine from both a provider as well as a practitioner perspective. And these include the onboarding, training process, review of the provider's qualifications and suitability. Thanks for also sharing with us on the mechanism in place with regular monitoring of quality standards while endeavoring to provide the medical care via telemedicine. It is also important for us to recognize as individual practitioners these unique limitations while providing medical care through telemedicine. So we would like to thank both Prof. Raymond and Dr. Andrew for giving us an overview of telemedicine from both the different perspective of telemedicine in Singapore. We will now take a 5 minutes break and we will reconvene after 5 minutes to go through the case discussion. And we would like to request for Dr. Andrew and Prof. Raymond to stay behind as well for the panel discussion. Thank you.
Hi, good afternoon, everyone, and welcome back. I'm Jingwen from NHGP. Together with Ying Xian, we will be your facilitators for the dialogue session this afternoon. In addition to Prof. Raymond Chua and Dr. Andrew Fang, we have another two panelists with us today. It's now my pleasure to introduce our third panelist, Prof. Tirumurti, a distinguished figure in the field of medicine and medical education. Prof. Thiru is currently an adjunct professor at Duke NUS Medical School and serves as the director of the Professionalism Development Program in the Office of Academic Appointments and Development. Prof. Thiru pursued advanced training in internal medicine and dermatology. He played a pivotal role in Singapore's healthcare landscape, founding the SGH Dermatology Department in 2002, where he served until 2017. Prof. Thiru has also been instrumental in advancing medical ethics, establishing and leading the Singapore Medical Association Centre for Medical Ethics and Professionalism till 2016. Throughout his career, Prof. Thiru has held significant roles, including serving as Group Chief Medical Officer at IH Healthcare from 2017 until his retirement in 2019. He also brings a rich academic background in healthcare ethics and counselling, holding master's degrees in both fields. Our fourth panelist is Dr. Gary Kang. Dr. Gary is an accomplished family physician and healthcare leader in SingHealth Polyclinics. He is a fellow of both the College of Family Physicians Singapore and the Academy of Medicine Singapore. In addition, he holds an MBA from NTU Nanyang Business School. Currently, Dr. Gary serves as a director in the Clinical Services Department at SingHealth Polyclinics, where he oversees essential processes that ensure safety and high-quality care in government clinics. He also leads the remote care work group, spearheading innovations in telemedicine to enhance patient care. So please join me in welcoming our four panelists as we dive into today's case discussion. So I'll now be sharing slides on today's case. Okay, so was wondering whether everyone can see my slides? All right. Okay, so today I'll be presenting on Madam Tan, an 80-year-old Chinese lady undergoing a video consultation accompanied by her domestic helper. So Madam Tan has a past medical history of cerebrovascular accident with left hemiplegia, poorly controlled DM with DPP-4 inhibitors initiated 2 months ago, hypertension, hyperlipidemia, and mild cognitive impairment, with her last MFC being 24. She is currently on medications such as antihypertensives, OHGAs, including a DPP-4 inhibitor, as well as aspirin. Madam Tan is widowed and stays with a domestic helper. She has no children. She has a sister who visits her once a week. Financially, she is self-sufficient, assessed capable of managing finances and personal welfare matters. Functionally, she is wheelchair ambulant in the community, and her basic activities of daily living are minimally assisted by her helper. So during her video consultation today, in terms of her chronic disease management, her average home blood pressure readings are at about 160 to 90 millimeters mercury. Her HbA1c done 1 week ago was about 9%. And during today's consult, the domestic helper reports that the patient has developed a back rash for the past 4 to 6 weeks. You are unable to obtain further details of the rash from the patient, and despite your best efforts in communicating with the patient the need for a face-to-face assessment, the patient reported challenges in attending a physical consultation due to her being wheelchair-bound and lacking caregiver support for transportation assistance. Madam Tan also reports running short of chronic medications and needed a refill. So to summarize, Madam Tan is an 80-year-old wheelchair-bound patient with a history of poorly controlled chronic conditions, and during her video consult, she reports a subacute onset of rashes. We would now like to poll the audience, so probably Chester can help me with the poll. And what would you like to do in this scenario? So knowing, from an ethical perspective, so knowing that this patient has a difficulty coming to the clinic, and how will you manage acute conditions? So will you insist that she comes for a face-to-face consult, continue to manage her through telemedicine, thirdly, arrange for a home visit as soon as possible to help her, or fourth, refer to a dermatologist for further evaluation? We'll give ourselves a good 10 more seconds for this poll before we go on to the next poll. So I think most chose arrange for a home visit as soon as possible. Okay, we go on to the next poll. Okay, so bearing ethical principles in mind, so as a doctor conducting the video consult, how will you proceed pertaining to managing her chronic conditions? Will you is this on a face-to-face consult due to poorly controlled disease, or secondly, top out chronic medications for a week and arrange for transport for a face-to-face review, or continue managing her care through telemedicine, or last but not least, arrange for a home visit within 1 week? Okay, so we give ourselves about maybe about 20 15 seconds more to answer this question. Okay, I think most of us will choose topping up chronic medicines. Okay, you can end poll. Thank you. Okay, so okay. All right. So there are various tools available for us to analyze ethical dilemmas, and one of them is this 4-box approach, which we can use to analyze ethical dilemmas, for this case in telemedicine. So to recap what we have learned in previous MME webinars, the 4 boxes method organizes ethical issues into 4 categories, such as medical indications, thinking about beneficence and non-maleficence. Secondly, patient preference regarding respect for autonomy. And thirdly, is about quality of life, balancing beneficence, non-maleficence, and autonomy. And last but not least, contextual features, using principles of justice and fairness. So with this case in mind, I would now like to invite Dr. Gary Kang to share his views on the medical indications pertaining to this case of telemedicine. So Gary, over to you.
Okay, good afternoon, everyone. Thanks for inviting me, and happy to be in this panel where there are so many distinguished doctors and yeah. And so anyway, looking at this case, I mean, we run SHP runs their own telemedicine service, and I think 80 years old is quite rare lah. That's the first comment. It's quite rare. We don't get many of them. But during the COVID wave, when all the people were working from home, right? Many of their children preferred to go through this telemedicine to so-called bring their mother or their father, right, to the clinic, and we would think that there's some problem with the technology, right, where old people don't know how to use, but there's a group of these older folks, right, who are actually quite tech savvy, and they are able to use this. Looking at the box, I mean, just talking about the patient, the first concern, I mean, I have to jump the gun a bit, that the first concern is whether the patient has enough decision-making capacity, because there was a mention that she has MCI, and I also want to know, when is the last mental state examination done? Was there any decline since? So it may not be obvious immediately, and of course you can, if the patient sees you frequently, you can look at the case notes and you can see what was there anything done in this aspect. And also the helper, right? The helpers are kind of a good resource in terms of history taking and all that. But then again, you want to know whether the helper was changed recently, whether the helper has the maturity, right? And whether she has enough mastery of the care components of the patient. Also the education and the language competency. I've seen helpers that can speak the language of the patient, like they can, speak Mandarin, and they know exactly what's happening. They can even tell you what's the color of the medicine and how many times you take a day. So those are very impressive helpers. So if the helper is like that, it will be good. It will help with the telemedicine a lot. Then also the acute problem. Okay, I talk about the problem. So the acute problem is a rash. So just looking at the photo or the picture, the spot diagnosis was a bit worrisome, because it's quite bullous-like. Okay, I'm not an expert in derma, but bullous-like. Then I think whether is this bullous pemphigoid. Then what are the other differential diagnoses? Maybe herpes zoster. Could it be some infection, or is it part of related to a pressure sore that's nearby? knowing that the patient doesn't move much. So just looking at this, I have a bit of difficulty coming to a decision what the diagnosis is. And also we look at the other thing is that she had the linagliptin started recently, so DPP4. If you look at the literature, there may be a possibility of it causing a drug-induced bolus pemphigoid. So from just looking at this and on the face level, can I ask enough more history about this? I don't know, but the feeling of the need to refer to a dermatologist or maybe even a more urgent type of with a look of this patient is in my mind when I see this patient. Yeah. So then how about the chronic problem, right? Chronic problem, you look at diabetes, not very well controlled. So on metformin, on linagliptin. So then I want to know also whether I'm the usual GP who looks after these conditions. So if I'm not, then maybe she sees one of my colleagues more frequently rather than me, and she's only coming for this acute problem. And if I'm not so confident, then I may not want to make any comments on the control, but it's poor control and needs to be acted on. So you want to look at the trend, want to look at the previous meds that are being given. So for chronic disease, of course, it's always important that the patient goes back to the usual doctor that have been seeing her, because the records are there. And only with this information that you can make a more, the doctor can make an informed decision whether to make any adjustments to the medication. So of course, I also want to ask about compliance, whether there's any, the administration was correct of the, the administration of the medicine was correct. Then I need to look, of course, whether the DFS was done, diabetic foot screening, and the DRP, diabetic eye screening was done. And all this cannot be done over the telemedicine. But it gives me an opportunity to ask and to clarify. Hypertension quite high, so if the helper can help, I definitely ask the helper to do a stat reading. Then if it's high, we ask about the symptoms, whether it's symptomatic. Pertaining to the stroke, I also want to know what's the baseline functional status. In fact, I want to check one if it was not done recently. And of course, on a video, it's very difficult to do that. Yeah. So yeah, these are some of my considerations for the medical indications part. Yeah. Thanks.
Yeah, thank you, Gary, for sharing the medical indications for this case. Bear in mind ethical principles or doing good for the patient, as well as not doing harm. You even talk about the caregiver wise, which is very commendable, as well as highlighting certain family medicine principles such as continuity of care, which you all value a lot. So indeed, telemedicine does probably have a role in treating and diagnosing certain medical condition. And I guess the effective delivery relies on the adherence to certain regulatory standards. So we probably would like to seek Prof. Raymond's inputs on the regulatory standards that is applicable for this case of this telemedicine of a poorly controlled chronic patient presenting with acute onset of rashes.
Thanks, Xing-Wen. So I think from a regulatory principle, we have talked about the professional care. So I would then say at the licensee level, at the licensing and the business owner, the licensee, as well as the clinical governance officer, would then have to ensure that, there is clinical protocols that's in place together with the doctors, in identifying which are some of the suitable patients that is necessary for telemedicine care or in-person care. And I think we talked about whether the standard of care in this case, can it be adequately done through telemedicine, or should it be better done in person itself? Especially for dermatological conditions, I've stopped practicing, so I won't be able to advise on that. But I think from past clinical experience, can you actually just see it through a camera? Do you actually need to see the rash itself? Because sometimes even dermatologists, you also need certain forms of specialized equipment to be able to see the rash itself. Whether just by seeing the rash, can you actually reach adequate diagnosis? Is it just one rash? Is it how widespread is the rash itself? It's another thing. The onset, the duration, and then I guess it's not just about the current care itself. Then I guess it's the follow-up care. do you then say, okay, you know, do you say there's a follow-up care in terms of if the rash doesn't recover, do you then say you have to come and see in-person care, you know, or do you need to refer to a specialist? Do you put in necessary protocols to ensure proper follow-ups itself? Because if the person don't recover, then what next for the patient? You know, are there alternatives itself? Because we also say that there are certain limitations to telemedicine, and when there's a limitation, then do you document it down? You say this based on your, you know, based on the current view that we have seen today, you know, it is a 1 cm rash. The patient did not say that there is any other areas of rash, you know, therefore, you know, this is my preliminary diagnosis. I've advised the patient that if the rash deteriorate, do not recover, you know, etc., etc. So I guess this is, I would say, when we break down the processes from the licensee, the clinical governance officer, and the professional end, you probably got to see before how to select the patient. Once you've selected the patient, fine, you still give, I mean, this is not acute that you cannot say that you cannot do a telemedicine. You can still do a preliminary telemedicine consult. Once during the telemedicine consult, then you have to assess, can this be continued? Can this be continued itself? What's the clinical assessment? What's the literacy of the patient in terms of giving you the diagnosis, in showing you the signs and symptoms? And then after that, even if you say, okay, fine, given this care, what's the follow-up care? Because it is not just about one episode. You know, I think medical care is about how do you actually ensure continuity of care? Do you provide alternatives? And if you don't recover, do you say that either you come back to see me or there's a referral processes? You know, and then even the medication itself, you know, you also got to advise on once you've been given this medication, if it doesn't recover, do you come back and see? Because sometimes you may diagnose, let's say you think it's an eczema, you know, and you gave a steroid cream, but it didn't help and it got worse, you know, because maybe you couldn't see just via a telemedicine whether it's an eczema or it's a fungal, you know, then what happens? I guess these are some of the things that you have to put in place in terms of the protocols.
Thank you, Prof. Raymond, for sharing your wisdom regarding this past, present, future framework for telemedicine. I think past is what has been said so far, present is the patient now, and future for future TCUs and stuff. So that's a very good framework for us to follow. So probably I would like to now ask Dr. Andrew regarding maybe in terms of this respect for autonomy or patient preference, what are your considerations for this case?
Okay. Yeah, I would just maybe like to echo what Gary said. This point is a very difficult case and really not the typical kind of case that we usually encounter over telemedicine. So as not to scare everyone off. I would say there's still room for telemedicine. Probably don't want to dismiss it, like what Prof. Raymond said. So there's still opportunity to do some preliminary assessment of the patient, and this is really an opportunity to still engage the patient. When the patient has come ask for help, I shouldn't just say, okay, go somewhere else. So it's really the opportunity to engage. Don't want the patient to say, actually, maybe next time, if I still have a problem, I still don't use telemedicine, when really we could still help the patient. So those are some things to consider. But so coming to autonomy, yeah, definitely, I think like what Gary mentioned, should make sure the patient has the mental capacity to make the decision. I think I won't cover that since Gary already spoke about it. But also make sure the patient is not under any undue pressure, because I mean, in this case, there's the helper. I don't want to be cynical, but sometimes it could be because the helper doesn't want to bring the patient down to the clinic, so it's very inconvenient. Then yeah, just do a telemedicine, settle the AMA's issue. So there's something to also just consider. And then over telemedicine, really, we can't really tell whether very well whether the patient's under that duress or yeah. So we probably need to be a bit more mindful of that part. Yeah, but I think coming past all that, assuming the patient has mental capacity and we kind of find that it's reasonable that the patient is not under any kind of pressure, then it's really doing that risk-benefit assessment with the patient. Make sure she understands the risk of misdiagnosis, and what if we actually don't get to do the full examination of her skin to see if the extensiveness of the condition. So doing a risk-benefit analysis, and also to just understand the strength of her inclination to do telemedicine. Maybe she's like half here, half there, and she's actually still keen to go to the clinic. Then we may still say, hey, yeah, why not go down just downstairs? Yeah, that kind of thing. So I think those are some of the considerations. But eventually, if she really wants to proceed with a telemedicine consult, I think we can do so with some things to mitigate. So like, I think Prof mentioned some clinical protocols. So perhaps for the acute condition like the rash, really is to make sure that we have good lighting, good video quality. It has to be done over a video consult, not a phone consult for this case. Make sure that the helper is at least able to give some history. I mean, if the patient is not able to give, at least the helper who has been taking care of her, maybe helping with her showering, could give an indication of the progression of the rash itself. And then for the chronic condition, getting the BP to be measured live in case there's really concerns of inaccurate blood pressure, checking the blood glucose in front of us in the camera. And then also perhaps advising on the red flags after the consult, things to be concerned about, to watch out for. And then maybe even offering to engage the sister who's not around to maybe follow up, and maybe if she's coming once a week, maybe she could make an additional visit to see the ama or the patient a bit sooner, given that now we are aware of these concerns. And then I guess other things would be like trying to arrange a follow-up appointment for the patient. I think this was mentioned, and definitely having proper documentation to say we've gone through this shared decision making, apart from the usual documentation that we would have done. So I think these are some of the things to do. And I guess also thinking future will be more of managing the future expectations, because this is really a tricky case. I think it may not be the kind of thing that we want to encourage always doing telemedicine for these things. So maybe if we decide to proceed, maybe advise her that, hey, maybe in future, it may not be the wisest to still do this, given the limitations. So these are just some of the considerations.
Thank you, Andrew, for sharing the considerations. I think I like the part about consent, where you talk about it, as well as the mental capacity part as well. And thanks also for sharing some practical tips on how, as practitioners, we can help for this case. So then next to Prof. Thiru, Prof, is there any wisdom you should like to share regarding quality of life or contextual features for this case?
Okay, I think the question here is obviously one is the medical part and then the patient's perspective. I think the medical part, as you all have recognized very clearly, there are two red flags, okay? Basically, the current chronic condition is getting out of control, and then there is a new disease which seems to be widespread and spreading, which of course both of them would suggest that really best beneficence that we can derive for this patient is really a face-to-face consult, an accurate diagnosis of the skin condition, and a proper plan, even maybe to start treatment as an inpatient to stabilize before the patient can be discharged, right? I think the respect for autonomy has also been raised, this point about the patient's stroke, the patient's MCI. We also, I think the point raised again is how much influence does the helper have over, or the helper, or the other way around, and maybe the view of the sister to really understand what the wishes of the patient is, right? And I think that sometimes can be difficult. So again, that tends to forward that actually to respect the patient's autonomy, although she has disadvantaged in terms of coming and making all the efforts to come. Actually, when we don't really understand the issues, we may not be even actually respect autonomy, because understanding the impact of the disease has on the patient. That means although we talk about autonomy, one of the important things is actually we should talk about respect for persons, right? In this person, the disease itself actually is impeding on the autonomy. And by getting the patient well, actually it improves the autonomy. So I think those were the main points you will consider. I think basically we are just using this as an educational opportunity to recognize when there is an ethical dilemma. We can use this tool in terms of collection and collation of the data. And then I think in this case, we can summarize that the medical indications and the patient's preference may be a bit of a conflict. And then I think Andrew and all have said how you resolve this by negotiation with the caregiver, the patient, and the sister to take it to the next stage. Over to you, Jingwen.
Okay, thank you, Prof. Thiru, for sharing your wisdom. Yes, indeed, for this case, I think some ethical principles in conflict are autonomy versus beneficence and non-maleficence. So, by respecting her autonomy to adhere to video consults, it may compromise the thoroughness of our healthcare assessment, particularly for her skin conditions and poorly controlled chronic conditions. So, for this, we probably, in the interest of time, we probably have to go to Q&A now. And I think there are some questions in the chat. So, thanks. Please keep these questions coming. There are some questions which Prof would like to answer, Prof Raymond would like to answer live. So maybe we'll have Prof Raymond to help us answer some of the questions which you'd like to answer live in the chat.
Thanks, Jingwen.
Okay, thank you.
Okay, I've been seeing the Fast and Furious Q&A session itself. So I thought it would be good that I may not be able to answer all, but I've tried to cluster a few of them together. So for, I think Chengek and Kok Chi has asked about things to do with medicines itself. So whether travel medicines can be prescribed through telemedicine, and whether, COVID-19 vaccinations can be advertised or not. Maybe I'll take the question on travel medicines, whether it can be prescribed or not. I guess from even if it is your patients, existing patients, I think when you are talking about just dispensing and prescribing travel medicines for patients to travel, there is still risk involved. And I think maybe I can also ask some of the practicing practitioners here to weigh in. But I would say even if you give Dimox, there is a lot of side effects. There is you also need to understand the conditions of the person. Even if you say that the person is totally fit and all these things, there's still side effects that you have to then advise the patient on. I would say that there is still a need to, even if it is not face-to-face, a teleconsult will still be required to go through what are some of the indications, what are some of the risk side effects of the medication, and ensure that all these are properly documented. Ultimately, I think a lot of things that we do is to ensure that there is proper communications, proper documentation, and advice to the patients. No matter how low risk we think there is nothing called zero risk, and I think because there is trust by the patients on our medical profession, and that we owe a duty of care and a standard of care to our patients, there is also a need to ensure that there is at least a minimum standard, and of which I think for travel medicines, at least I would say that there should be a need for a teleconsult. In terms of advertising COVID-19 vaccinations, can or not, if it is a national program, under the our national vaccination program, actually all these, if it's endorsed by the government, if it is Healthier SG program, etc., it is actually exempted. So you can advertise some of these vaccinations, but because it is under the cover of a national program, and it does not also mean that once you advertise COVID, you can also say that it can be usual price $20 and you slash down to $5. Anything, it is still must be factual and accurate, and you cannot be seen to be soliciting the service by providing certain forms of discounts, etc., or inaccurate information. Then I bring on to another point itself in terms of, I think Chun, William Chan, and Priya talked about whether there can be minimum fees, minimum time. It is very important that I just wanted to say, I do not want to focus a lot on our efforts in trying to control or regulate time by stipulating minimum duration or stipulating minimum fees for our providers here. Or even some people also tell me, why don't you stipulate number of MCs, that can be given? Ultimately, a lot more should be focusing on how telemedicine is being practiced. We should be focusing our efforts on what benefits the patients, what is the sufficient information, clinical assessment that is needed for the patient. I mean, even for physical consults, to be fair, some patients walk in and out within a few minutes. I won't say a few seconds, at least a few minutes. I won't even dare to say, I can say it is less than 2-3 minutes, for some, which is very simple and relatively simple. And I think the fees, the duration should then commensurate with the patient profile, the clinical conditions, the signs and symptoms that be presented by the patient, and the expertise of the family practitioner, because there's a lot of factors that comes into play when you see a patient. It is not just about the patient profile, the patient signs and symptoms, the risk of the patient. It is also about the expertise, of the clinician itself. If you are very good, you may diagnose something very fast, as compared to someone who is probably new, into the sector. So I would say that rather than focusing our efforts on regulating fees, and time, it should commensurate with the clinical assessment. And maybe at this point, I just wanted to open up maybe to the rest of the practicing practitioners here. Maybe do you all have anything to say with regard to prescription of medicines, or even what are your views about stipulating minimum fees or time?
Thanks, Prof. Raymond. Maybe we'll also get to build on this. Maybe we'd like to invite Dr. Gary to weigh in.
Yeah, so I mean, I can talk a bit about our experience setting up the telemedicine service. We have one service that's more for chronic conditions, and that's like for what we call for appointment. You make an appointment now, and then you'll get be seen like a few weeks later or a few months later. Then there's one that we have a same day service, which is a bit like what the private telemedicine are offering. So they will get seen on the same day. Those are more for acute conditions. And we have done a lot of time motion study, and generally the doctors in polyclinics are quite careful. And in fact, they are more careful than I expected them to be. I mean, they are very safe, and they ensure if the patient is not suitable to be seen, they'll get them to come down face to face. But we've done time motion studies. So for patients who are more chronic, in fact, they take a longer time in telemedicine than when they are seeing in face to face. We're not 100% sure where the time is going, but we know that because when the patient comes in, we'll tell them a few disclaimers, right? Like, you got to consent to this because the video and the audio might not be good. We have a fixed thing that we tell the patient, and after that, some things like the side effects of medicine and all that, you might want to tell the patient first, because the patient doesn't have the benefit of going to, in polyclinic, after seeing a doctor face to face, you go to the pharmacy, right? They may not have the benefit to go down and to see the medicine by itself and get counseled properly. So you might want to say a few things on that. So there's some safety part going on, telling them there's some disclaimer, some conditions that in the telemedicine may not make the consultation so good, So there are some time loss. But when we look at the acute conditions, with the same day ones, like coming for URTI, they take a way shorter time to see a patient. And someone did ask us, is it because we don't do physical examination and all that? And that's the issue there. That we don't do physical examination for something like URTI. Is it okay, And then we noticed that the people who choose to do telemedicine, right, their conditions are generally milder, and they are a self-selected group of people that they already, they know that they are not so serious, and hence they they are willing to try this mode of consultation. That's what we think and what we observe, but yeah, it's a bit subjective. Sorry, yeah. Okay, maybe Andrew has more experience in this aspect. Yeah.
Yeah, how about
Yeah.
Andrew, any wisdom to share, some practical tips? I mean, bearing in mind regulations as well as ethical aspects of telemedicine.
Yeah, so I think like for URTI, what Gary said, most of the patients kind of know how to self-triage already. So generally the patients that we also see are those that tend to know that their symptoms are milder, and that's why they choose to do over telemedicine. But of course, not all cases are that clear-cut. Sometimes they have different expectations also. But I think doing some pre-consult probability of triaging does help. Definitely the younger patients, if the symptoms is just 1-2 days, milder, they don't have any like other past medical problems, comorbidities, I think it's still reasonable to proceed with a teleconsult. I know there's a question about the lung auscultation. I mean, true, it is ideally should be done, but I think as clinicians, how many times have we listened to a lung and in a URTI case that actually turns out, or ARI case that turns out to be truly lower respiratory tract infection? I think that's something to consider. So I think it's really, the auscultation is really just like an additional diagnostic test that we consider doing for that patient. Yeah. So that's my thoughts on the URTI lung auscultation part. In terms of the travel medicine, sorry, I just backtrack to that part. I agree. I think there should be a consultation. It's not just prescription of the medicine. It's really part of a whole travel medicine preventive consult. So really, you have to find out where the patient is going, how long, any risk, vaccinations up to date, what are the things you may be potentially exposed to. And then, of course, the medicines is just one part of it to kind of prevent any or to quickly treat anything that they may potentially have during the trip. And of course, counseling on the side effects and how to use the medicine, things like the altitude sickness medicine, istazolamide, probably need to counsel patients a bit more if they're not so familiar with such medications. Yeah, so that's my thought on the travel medicine part. So the other question I think was asked was the time, the duration of the call. I agree with Professor. I think very hard to set a certain minimum time. I think in physical clinic consult also, we don't do that. Some patients really, as a patient, you see in the clinic, so you see, hey, wow, in and out so fast. Yeah, so there is, I think, something that may be more prevalent in telemedicine, but it also happens in physical clinics. So for us, I mean, we don't set any benchmark or minimum time, but we do tell doctors if you don't fully address the patient's concerns, if the patient complains that you're rushing, then we will definitely look into the consult and see whether you did a proper consult, and time is definitely one of the things that we look at now. Yeah. Then the last thing about fees, I also don't know whether increasing fees will guarantee better healthcare outcomes or care for the patient. My concern is to increase fees that will just increase our overall healthcare costs to patients when telemedicine is meant to actually reduce costs and create more convenience to patients. So yeah, I mean, I think those are the 4 things that I heard from the other panelists.
Thanks, Andrew, for sharing as well from your perspective. I think in the interest of time, perhaps we would like to invite Prof. Thiru to also help us to share some of the comments that's been currently shared by our panelists here, as well as some take-home message for our audience on the call. Over to you, Prof.
So I think I will first try to answer what Raymond raised about regulating time and fees, right? Now, we must be very clear. The law can tell us what not to do, right? What Raymond says, you don't prescribe hypnotics or diazepam or something over, right? But really, the law cannot tell you how to do things well, right? And I think this is where I think Raymond presented very clearly under the HACSA. We have actually put the 3 players in, right? That means basically it's a licensee, all right, the principal officer and the clinical governance officers, right? So there is a system. So there's certain things are really better off bringing under the quality control framework if you want to improve care. right? Rather than to make rules. I think this is something we need to understand. Number two is there's accountability, right? People who are going to be accountable. And I think that part of bringing the whole organization, as Andrew said, is very important. That means it's just not the doctors, but the owners and the administrators must all play a part to actually help to improve the quality of care and not just to comply with the regulations, I think. And for those of you who are concerned, I think Raymond again reassured us that they are looking very clearly at the advertising regulations of all three partners and how they are behaving, because that's really the thing where abuse can occur and patients can be enticed inappropriately to use services that may not be suitable for them. So I think in summary, really, I am really glad Raymond very clearly explained to us the big issues. And I think we hope going forward, I think if we have set the ground rules for this, we can now embrace technology in better ways to give access to our patients. Remember, the main thing is now access. And triaging, at least initially, to give the first assessment by using telemedicine. Over to you, Jingwen.
Thank you, Prof. Thiru. I think the point about accessibility is very important to all of us. So I think Prof. Raymond may have some comments to make. So over to you, Prof. Raymond.
Thank you, Tingwen. I think I just wanted to reassure everyone here. I see a lot of questions, and probably we may not be able to answer most of them, but we will take back some of them, and we will see how to address them in our circulars or our FAQs that will be coming out. But I just wanted to let all of you and assure all of you that please do not let the recent examples tar or progress how we are going to look at telemedicine care. Telemedicine is there for a purpose. There in every care models, in every profession, there will be certain I would say minority of certain providers that may sometimes not abide by rules, and therefore we may have to take enforcement actions. It does not signify that this is the majority of the providers here. If you actually do know what are some of the guardrails, do know how to practice professionally, ethically, I don't think that we are going to enforce on every case that happens. You know, it must be of a majority of a significant number of cases or how you run a business that will ensure actions being taken. I mean, if one or two, sometimes, due to certain protocol oversight or access, etc., I think we will have to take each case into each case and review on a case-by-case basis. So I want to assure all of you that please do not let the current examples or whatever the media reports have been coming out to tar the reputation of the family practitioners, nor impact or stifle the innovation of telemedicine itself. I think there has been some example with regard to limited training. How do we work with CFPS on determining what are some of the medical conditions that are suitable? I think Richard mentioned whether we can support more training for those new providers that are coming out. I think these are something that I think MOH can work together with CFPS and the various colleges on. I think we can see how to make it clearer in terms of coming out with training as well as also conditions. But I don't think we can come up with exhaustive list of conditions. Ultimately, a lot of things will have to determine on professional judgment itself. And I think there's another one by Kok Chi who mentioned about review of legislation. I think we also want to ensure that we will definitely be looking at the regulations. In fact, at the ministry and HSA level, we are doing a transformation review at the regulatory level that cuts across services and products now to see how we can look at more consolidation of our services, of our regulatory models, so that we are much more clearer to the stakeholders itself. Because we are also starting to see the confluence of regulations across services and products, like how I mentioned just now, and professions. So these are some of the things that we are working on itself. And I think Pui mentioned about platform. I think definitely we are looking at how we can also provide better guidances to platforms, because currently I think that there's a lacuna in terms of the regulations for the platform itself. And this is something that we will also be going forward. So there's, as we evolve, I think in terms of a care model, I think there's a lot of things that we will, as regulators, as professional associations, will need to work together to ensure that we keep pace to the evolving developments. But again, I just go back. We want to ensure safe and effective care. We really are not here to kill off the telemedicine model. Thank you.
Oh, thank you, Prof. Raymond, for the reassurance, so that we can continue to provide accessible care for this group of patients who really need and benefit from telemedicine. So in the interest of time, I'd like to hand over to Dr. Suraj for his concluding statements for this webinar.
Thank you, everyone. It's been a very interesting afternoon. I hope everybody took some lessons from this webinar. There's been much illumination, and it's now a lot more clearer about the role telemedicine can play and how we can make it beneficial for patients in their best interests. I'd like to thank all the speakers. Everybody was excellent, and it's a real team effort. So I know that telemedicine, we strive to aim for the same goals of medicine that we try to do in a face-to-face consultation, but definitely, as we have seen today, there are challenges, and every patient is different. There's a lot of context involved. But as Raymond says, reassured us that, telemedicine is not something that's bad, and the government will come down hard on you. I mean, the MOH will come down hard on you just because you didn't follow certain rules. But yet each doctor has some responsibility to work within the regulatory framework and then use the ethical principles as they deem fit. I mean, I agree that we cannot give everybody exhaustive lists of things to do. Then the guidelines become very prescriptive. And then people will start complaining that there's no flexibility, right? So actually, each doctor has a responsibility in exercising ethical principles. And this is what these MME webinars are all about. It's for all the professional bodies. We're trying to bring up understanding of ethical reasoning and decision-making in our everyday practice. So with that, I would like to thank everybody once again, and I hope everyone has a good weekend. Please don't forget to fill up the feedback poll. It helps us create. I know everybody's asking for more webinar events, but really these webinar events take up a lot of work.